Everyone's talking about GLP weight loss drugs like Ozempic and Wegovy. But what if I told you that up to 40% of that weight loss is muscle and bone? What really happens inside your body when you stop these drugs might shock you. And it's the reason many end up worse off metabolically than when they started. What no one tells you about GLP-1 weight loss. The clinical trial results look impressive, an average weight loss of 14.8% over 48 weeks with GLP-1 medications like Ozempic and Wegovy. Compare that to a low-carb dietary approaches, which achieve about 9.8% weight loss over a longer time frame, and the pharmaceutical option seems clearly superior. But weight loss percentages tell only part of the story. The more important question is what kind of weight is being lost, what happens at the cellular level during treatment, and what occurs after the medication stops. These details reveal a more complex metabolic reality than the headline numbers suggest. Start with the composition problem. GLP-1 receptor agonists work by mimicking a naturally occurring intestinal hormone that regulates appetite, slows gastric emptying, and modulates insulin secretion. The synthetic versions used in medications provide continuous, high-level stimulation of GLP-1 receptors at doses far exceeding natural physiological levels. This pharmacological approach produces rapid weight loss, primarily through appetite suppression. Patients simply eat less because they feel less hungry. The problem emerges when examining what's actually being lost. Up to 40% of the weight loss with GLP-1 medications comes from lean mass, meaning muscle tissue and bone density rather than fat. Clinical studies show this lean mass loss ranges between 25 to 39% of total weight loss over 36 to 72 weeks. For context, low-carb dietary approaches tend to preserve significantly more lean mass during weight loss. This distinction matters because muscle is a major site for glucose disposal and energy metabolism. Losing substantial muscle loss reduces resting metabolic rate, making it harder to maintain weight loss long term. Bone loss increases fracture risk, particularly concerning for older adults. The result is weight loss that can actually worsen metabolic function despite improving the number on the scale. The digestive dysfunction threshold. GLP-1 medications slow gastric emptying as part of their mechanism. This delay creates feelings of fullness and reduces food intake. In therapeutic doses, food that normally empties from the stomach in 3 to 4 hours might linger for several hours longer. But the line between therapeutic effect and dangerous dysfunction is narrow. Some patients develop gastroparesis, a condition where the digestive system slows so dramatically that food remains in the stomach for 24 hours or more. The intestines can become effectively paralyzed, unable to move food through normal peristaltic contractions. Research shows the GLP-1 group was 25% more likely to develop gastroparesis at 18 months compared to control groups. Clinical presentations include persistent nausea and vomiting, severe abdominal bloating and inability to tolerate oral intake. In extreme cases, patients require surgical intervention to insert feeding tubes or decompress the stomach. The condition can be actually life-threatening, particularly if vomiting occurs under anesthesia, creating aspiration pneumonia risk. What begins as appetite control can cross into digestive paralysis without clear warning signs. There's also a big psychiatric signal. GLP-1 receptors exist not only in the gut but throughout the brain, particularly in regions that regulate mood, reward, and motivation. These same brain circuits that control appetite overlap substantially with pathways overlap substantially with pathways implicated in depression and anxiety disorders. That's critical. Recent epidemiological data reveals concerning patterns. Patients using GLP-1 medications show a 195% increased risk of major depression and a 108% increased risk of anxiety compared to those not taking these drugs. The research also indicates a 106% elevated risk for suicidal behavior, though the absolute incidence remains low at this point. These psychiatric risks emerged from real-world observation rather than clinical trials, because most trials excluded patients with pre-existing depression or anxiety from participation. This exclusion creates a critical blind spot. Patients with obesity have higher baseline rates of depression, yet the safety data doesn't capture how GLP-1 medications affect this vulnerable population. The mechanism likely involves disruption of neurotransmitter systems, particularly glutamate and GABA balance, which are essential for mood stabilization. The drugs may also affect dopamine and reward pathways in ways that alter emotional regulation. This pattern echoes Rimonabant, a weight loss drug withdrawn from the market after causing severe psychiatric effects, including a 2.5-fold increase in depressive mood disorders. Initial enthusiasm, rapid adoption, then serious problems emerging from real-world use. There's also a big metabolic trap you get involved with here. What happens after patients stop taking GLP-1 medications reveals perhaps the most problematic aspect of their mechanism. During treatment, these drugs stimulate fat cell hyperplasia, meaning the creation of new fat cells. The total number of fat cells in the body actually increases, though each individual cell remains smaller due to reduced food intake and lower insulin levels. When the medication stops, those extra fat cells remain. The body now has an expanded capacity to store fat compared to before treatment began. This increased fat cell population can rapidly refill, leading to quick weight regain. Studies show participants regain 2/3 of their prior weight loss within 1 year after stopping semaglutide. The regained weight tends to have a higher proportion of fat relative to lean mass, actually worsening body composition compared to pre-treatment baseline. Only 1/3 of patients continue taking GLP-1 medications after 1 year, meaning most people experience this rebound effect. In contrast, weight loss through low-carb dietary approaches primarily reduces fat cell size without significantly increasing fat cell number. When weight regain occurs, it happens more gradually because the body doesn't have an expanded fat storage capacity. This creates a metabolic trap where stopping GLP-1 drugs can leave patients in a worse position than before treatment, with more fat cells primed to store fat and less muscle mass to burn it. There is a natural alternative. The body produces its own GLP-1 through specialized L cells in the intestine. These cells respond to nutrient intake, particularly natural fats and proteins. Low-carb, whole food diets naturally increase endogenous GLP-1 secretion. Saturated and monounsaturated fats stimulate these L cells more effectively than carbohydrates. Soluble fiber and short-chain fatty acids from gut fermentation further enhance GLP-1 release. The key difference is timing and magnitude. Natural GLP-1 release is pulsatile and meal-dependent, finely tuned to the size and composition of what's eaten. The hormone acts for a short duration, coordinating insulin secretion, glucagon suppression, and satiety signals without overwhelming the system. This is a garden sprinkler compared to the fire hose of synthetic GLP-1 medications. Dietary approaches also improve insulin sensitivity by reducing insulin secretion itself, Lower carbohydrate intake means less insulin production, which helps shrink existing fat cells and improves metabolic function at the cellular level. The result is weight loss that preserves lean mass, reduces systematic inflammation, and addresses the root cause of metabolic dysfunction rather than suppressing its symptoms. Patients follow low-carb approaches often achieve sustained HbA1c reduction and drug-free diabetes remission. About 70% of patients who lost more than 15 kilograms maintained remission after 2 years, with 60% remaining off medication. These outcomes reflect true metabolic recovery rather than pharmaceutical or pharmacological symptom control. The clinical decision framework. The question isn't whether GLP-1 medications work. They clearly do, at least in the short term. The question is when they're appropriate and how to use them without causing more harm than benefit. The clinical algorithm starts with comprehensive metabolic assessment, fasting insulin, HOMA-IR scores, inflammatory markers, and body composition analysis reveal whether someone has underlying insulin resistance and metabolic dysfunction or simply excess weight. For most patients with mild to moderate obesity, dietary intervention should come first. A low-carbohydrate, whole food approach addresses root causes, preserves lean mass, and carries minimal side effect risk. GLP-1 medications become appropriate in specific scenarios. Patients with severe obesity and high cardiovascular risk who have genuinely attempted lifestyle changes but continue to struggle. Individuals with significant insulin resistance requiring more immediate intervention. Those exhibiting true food addiction, where compulsive eating behaviors resemble substance addiction. In these cases, the medications work best as adjuncts rather than replacements for dietary change. Starting with low doses and increasing gradually allows assessment of tolerance and effect. Regular monitoring of body composition ensures lean mass preservation. Nutritional counseling emphasizes adequate protein and fat intake to prevent muscle wasting. The goal should always be eventual deprescribing, using the medication as a bridge to establish sustainable eating patterns, then gradually reducing dosage as metabolic markers improve and patients gain confidence in managing appetite without pharmacological suppression. Successful transition off medication requires stable HbA1c and fasting glucose, improved insulin sensitivity, preserved lean mass, absence of significant hunger or cravings that could trigger relapse. So here's the core principle. The fundamental insight often missed in discussions of GLP-1 medications is this: metabolic health causes healthy weight, not the reverse. These drugs produce weight loss by suppressing appetite and slowing digestion. They don't directly fix insulin resistance, chronic inflammation, or hormonal imbalances that drive obesity and type 2 diabetes. Weight loss achieved pharmacologically can mask these root causes, leading to temporary improvements that reverse once medication stops. These explain the rebound effect, the lean mass loss, the metabolic trap of fat cell hyperplasia. The medications treat weight as the problem rather than recognizing it as a symptom of deeper metabolic dysfunction. Sustainable metabolic health requires addressing diet quality, particularly carbohydrate tolerance and insulin regulation. It requires reducing systematic inflammation through whole foods rather than processed alternatives. It requires understanding the behavioral and psychological factors that influence eating patterns. GLP-1 medications can be valuable tools within this framework, but they aren't standalone solutions. The number of Americans on incretin-based therapies has increased 587% in the past 5 years. As these drugs become increasingly mainstream, understanding their proper place in metabolic health treatment becomes critical. The impressive weight loss percentage deserves scrutiny rather than celebration. the composition of that weight loss, the metabolic consequences during treatment, and the outcomes after discontinuation matter more than the headline number. True metabolic health isn't measured by the scale. It's measured by insulin sensitivity, inflammatory markers, body composition, and the ability to maintain healthy weight without pharmacological intervention. That's the difference between suppressing symptoms and addressing causes, between temporary weight loss and lasting metabolic recovery, between treating the number and treating the person. Okay, thanks for watching. If you made it this far, I appreciate it. Please, if you have any comments or questions, leave them in the appropriate section, and we try to answer every question appropriately. Okay? Also, if you haven't done so, think about liking this video, subscribing to the channel, and sharing it with a friend. It helps us a great deal, and we thank you for that, but you also will be helping a bunch of other people. So have a great day.